I'm here today presenting on behalf of myself and Dr. Mallory, and we've been working on a new model for care to try and improve appropriateness of care for older adults, particularly those who are frail and nearing the end of life. The truth about this process when we talk to people about it is that everyone has a story and can relate to this material sometimes on many different levels. And so by way of that, this is our story. So this is Laurie Mallory's grandmother with her granddaughter. And Laurie's grandmother had Alzheimer's type dementia, and it was progressive to the point that she needed placement in a long-term care facility. And during that time, she was placed in a long-term care facility in the United States where they live. And during that time, there was a culture there where a lot of life-prolonging measures were undertaken. So at the end of her life, she had multiple visits to the emergency department, received artificial nutrition through tube feedings, and had a very difficult death as a result. And so part of that story was what I think spurred Laurie to look at how we deliver care, particularly at the end of life, and how we might improve that. This is a picture of my grandmother who passed away in November of 2009. And her death was one of my first opportunities to apply these principles on a very personal level to someone that I had known for many years and loved very deeply. Using the principles, I was able to help guide my grandmother and our family, our extended family, through the process of her end of life and how to make decisions around the medical care that she would receive at that time. And she experienced a very dignified and graceful death. She was in hospital for approximately 5 days prior to dying, but up until that time lived independently in her own home with some outside help from family members and from care providers. But she really experienced a death without great suffering, and a death that allowed us to come together and celebrate her life during the dying process. So there are many challenges that face us when we look at how we could deliver end-of-life care to frail older adults, particularly societal challenges, and certainly our culture is one of denial of death, and I'll talk about how our culture and language might impact upon the type of care that we deliver. And also the medical system itself poses many challenges to this kind of work. Issues with being able to recognize when death is near, the ability for healthcare providers to talk about prognosis, particularly in the face of uncertainty, and also the epidemic of assessment that's going on. That's really, I think, taking the human resources that we have, the very rich human resources that we have, and directing them away from care planning and instead focusing on assessment. And we'll also look at some examples of how these factors play out in real life, and I have some studies to show you as well in that regard. So first, our culture and language. This really, I think, is a case of history repeating. So if you look back 30 years in medicine at the pre-palliative era, so that time before palliative care was developed, particularly with the model of cancer care, what you found is that many people died in isolation, many people were not informed of their diagnosis, and as a result, many people suffered at the end of life. And this is an excerpt from a book that looks at the development of palliative care over that time period, and particularly the work of Dame Cicely Saunders, who was a nurse in the area, who was really starting to see some problems with how that care was delivered. So she writes, "It seems inevitable that a backlash to such blind optimism would arise. The belief in the cult of cure was so strong that it denied the very existence of dying patients as a class of people. Deaths, if they occurred, were aberrations. In the cult of cure, people did not die, they coded. A new social institution was needed. This institution became known as hospice." So when you think about the picture that's painted in that write-up, I think you could see that we've come a long way in palliative care in terms of empowering patients to really be a part of their care planning, to be informed. But if you look at how we provide care to frail older adults at the end of life, there are many similarities to the pre-palliative era. So this table just shows some of those similarities. And as I've said before, that philosophy of withholding information was very prominent in the pre-palliative era of cancer care. And so much now, it's not about withholding information as it is healthcare professionals not being comfortable discussing prognosis, particularly when people have more than one medical issue going on. But as a result, many people are not aware of the degree of frailty that they have, the prognosis that's associated with that. And there's really inattention to how people die. We pay a lot of attention to what we do to people at the end of life, but not a lot of attention to the dying process. As a result, frail older adults may die in pain and isolation. Comfort care may be delayed or withheld altogether due to lack of recognition of the end of life. And really, this presents a picture of insensitivity to the needs of the dying. And so I think you can see that there are several similarities between the pre-palliative era for cancer care and our current care protocols that we use in frailty at the end of life. And it really shows us that there's much work to be done in this era. In terms of the traditional language that we use, you can see that this culture of cure is very pervasive. So we think that we're accepting of death in our culture, but really the words that we use in the medical institution betray our comfort with dying. We use terms like, she was very brave and she fought until the very end, or heroic measures were unsuccessful, or someone has failed treatment. So these are all very value-based words that suggest that death is a failure, just as the write-up was saying, you know, that death was an aberration. And so really, what we're hoping to do is to help develop a more precise language. And this has been accomplished in cancer care. I think that, you know, receiving a diagnosis of cancer carries with it now some emotional connotations, and so that when someone receives a diagnosis of cancer, they may say, well, am I dying? And want to have information about prognosis. But if you contrast that to people with multiple medical issues who are older at the end of life, they may not ever have that, that sense in the back of their minds that, you know, death might be a possible outcome of this. And so instead, it's more focused on what treatment should I choose, not whether that treatment is really the best thing for their quality of life at that point in time. And what is the danger in this? Well, I think the danger in this is that people might feel pressure to choose aggressive interventions without really understanding what the options are. So another challenge that exists in our medical system itself is that of recognition. And certainly we know that physicians are terrible at recognizing when someone is reaching the end of life. And this is a study that just illustrates that. This is a study of patients in long-term care with advanced dementia. And only 1% of those with advanced dementia were perceived by their physicians as having a life expectancy possibly of less than 6 months. But if you followed people with advanced dementia for 6 months, 71% of those people actually died within that time frame. And if you compare that with the death rate for people with cancer, what you find is that really advanced dementia is a terminal illness. It procures a very similar prognosis to cancer and really should be approached in a very similar way in terms of cueing us that perhaps now it's time to integrate more palliative measures into someone's care plan. Another issue beyond recognition is that when we do recognize that the end of life is near, we often don't communicate that to patients and their families. So this is a study illustrating that issue. And what they did in this study is they talked to physicians and looked for patients who that physician was felt had a prognosis life expectancy of less than a year. And then they found 90 such individuals, and then they phoned those individuals and asked them what they knew about their prognosis. And what you could see is that for those with cancer, 71% were aware of their prognosis. But for those with heart disease, in this example, it's congestive heart failure, only 19% were aware of their prognosis. So again, it illustrates the fact that we've managed to advance the culture when it comes to single system diseases, such as cancer, but that much work has yet to be done, particularly for people with multiple diseases or non-cancer illnesses. And really, I think the communication barrier presents opportunities that are really lost. And what we know is that patients and their families want information. They're hungry for information about their medical issues and what they can expect in the future. There was a study done of substitute decision makers, usually it's the next of kin or primary caregiver, in an ICU setting. And what they found is that 93% of those people wanted more information about what was going on for the person that was receiving the ICU care. And we also know that information has a very powerful effect